Brought to you by Chemistry.
Hello listeners, and welcome back to Brought to you by Chemistry. I am Hiren Joshi, and today we bring you some bonus material from our interview with Dr. Hilary Jones. So let's begin.
So I've been a GP for 40 years and seen immense changes in general practice during that time. And it was probably 10 years into general practice as a GP principal that, I was aware that you could see one patient at a time in the surgery, which is a very important discipline, just focusing on that one patient. But you could reach tens of thousands in a broadcast and spread a broadcast message to millions of people. So when there was a public health issue, and the most recent one being, the greatest one for decades, which was the COVID-19 pandemic, reaching those people and giving them the information that they needed in order to protect themselves, and talking about changes in vaccination schedules and the importance of the precautions we took against COVID-19. You couldn't do this on a one-to-one basis in the surgery, but I was aware that you could do it on television and in the media.
So obviously your job is as a medical communicator. Why is this so important, particularly in the area of infectious diseases and especially in AMR?
Well, it's what has been so surprising during the recent pandemic is the level of ignorance in the general population. I think as scientists, we assume that the people have a basic knowledge of science, that they trust doctors, they trust researchers and scientists, but they certainly don't. They don't appear to all the time, just as they don't trust the government. So they are skeptical and they question, back in the day, probably what the doctor said was gospel and it wasn't questioned. But now it's much more likely that people will question scientists and go down the line of conspiracy theories that they might see on social media. So this surprised me during the pandemic. But even before that, there was skepticism about, MMR. There was skepticism about other vaccines. There was sort of a lot of concern, largely inflamed by a salacious media, about the side effects of antidepressants, about the side effects of all sorts of medicinal drugs, which had a really good value. So this was of concern to me, and I did two things. I took the jargon out of the communication messages and put everything in very simple terms, and explained from my point of view why it was so important to follow good guidelines with medical evidence.
I guess a follow-up to that, because obviously that is one of the biggest challenges in terms of public trust. How do you myth bust a lot of the conspiracy theories that might be out there? And you mentioned some of your strategies, like removing some of the jargon, trying to make things a little bit more relatable and easily accessible for the public. How do you and your producers, networks work together to create specific messaging?
It depends on the particular editors of different programs or newspapers. Some will take a more salacious, scaremongering view. It sells newspapers. Other editors want to be more responsible and will ask me for guidance as well. But often it's news-led. And the whole area of antimicrobial resistance is fascinating. You know that the previous head of the Department of Health,
Sally Davis,
sorry.
Yeah.
I mean, she's written a book on the subject. And it's fascinating, but even when penicillin was being produced for the first time back in the 1940s in Oxford, that they were aware that there was resistance to penicillin in certain organisms. So it's not a new thing, but because of the overuse of antibiotics in the last sort of 30, 40 years, we now face germs which are resistant, which are very virulent, and lethal. And there's still this pressure to overprescribe when it's not necessary, partly because we don't have enough diagnostic tests to see what we're dealing with. You know, as I've said on television in the last few days, you can't look at a sore throat and know what it is that's causing that throat. Is it a viral infection? Just because there's exudation, does it mean it's strep A? Of course, it could be glandular fever. It could be many different things, and you wouldn't necessarily want to use antibiotics in glandular fever, of course. So it's a challenge, and it's very difficult for a GP who's pushed for time, inundated with worried parents, to say, I don't think your child needs an antibiotic, because to try and explain why is going to take a long time. GPs don't have that time, so it's understandable that they reach for a prescription pad, and the patient leaves the room.
I was just going to ask, you were saying, obviously, we're kind of no longer in an era where people just implicitly trust what doctors say. People kind of tend to, quote unquote, do their own research and push back. Do you think that for that reason, it's particularly important now that people have a high level of scientific literacy so that they can actually understand what the scientists and doctors are saying and understand intellectually why it's correct, rather than kind of just throwing out the advice?
Yeah, absolutely. I mean, I wish that there was more science on television. You know, there's probably 400 TV channels out there, a TV in every room of every home in this country, and a woeful lack of scientific education. It's all about entertainment. And, you know, I tell my TV bosses this all the time, but, you know, there's probably less profit in talking science and making science sexy. I mean, we've got some very good people who talk about astrology and about various scientific issues, but they're few and far between. You know, I'd like to see more programs devoted to science and new techniques, new discoveries. How do we motivate our young people to think of a career in chemistry or biochemistry, you know, medicine, science in the future, if everything is centered around entertainment? So I think a job needs to be done there, and schools maybe could look at the curriculum. I don't think it's difficult to really influence children at a young age to get them involved in science. It can be made fun, and, you know, perhaps it would take preference over certain other subjects on the curriculum that doesn't seem to have changed for decades.
So, I mean, that's really interesting, and a question in terms of how to get people a bit more interested, maybe bringing a kind of hopeful angle to sort of this discussion on AMR, and with your experience of being a medical practitioner for 40 years, have you seen, you know, in the last 5 to 10 years, any cool, interesting innovations within our healthcare that has improved how we diagnose patients?
Yes, I've seen some advances, and I've seen some backward steps. You know, it wasn't, I mean, I remember when I first started in general practice, it was still quite commonplace to take a throat swab. You know, if somebody had a very inflamed pair of tonsils, we would do a throat swab, we'd send it off for culture and sensitivity, and we'd get the result back from the hospital within 3 or 4 days. So we'd know what we were dealing with. If they weren't on antibiotics and it was a bacterial infection, we could prescribe the appropriate one. Or if they were already on antibiotics and it was a resistant infection, we could change the antibiotic prescription. Not many GPs are using throat swabs at all. And of course, it takes a few days to get the results, and everybody wants everything like tomorrow these days, you know, or yesterday. So, you know, then they want that prescription now. There are practices that use rapid antigen testing, but they're few and far between. PCR might be used in hospitals, particularly for things like meningitis, suspected meningitis. PCR has been very useful in PCR on peripheral blood. The polymerase chain reaction has probably changed the management of suspected meningitis, and not everybody will have a spinal tap. A lumbar puncture might be unnecessary if PCR shows a positive result. and early treatment is begun. So I think innovations like this have been extremely useful. But as I say, throat swabs, we're not doing so much. And I don't know why they've gone out of fashion, but they're still very useful and much cheaper than PCRs.
Are there differences in how you would use diagnostic tests in different scenarios? So presumably you'd need faster diagnostics for emergency admissions, different kinds for GP admissions. Can you just expand on that a bit more?
Sure. We would always, with our medical training, try to manage a patient's condition based on what we can prove. So on an accurate diagnosis. If we know exactly what we're dealing with, then we're onto a winner. Guessing is not good news. It's not scientific, and it's not good for the patient. So, for example, in general practice, the kind of diagnostics that we use, obviously blood tests are commonplace. Occult bloods are sent to people's homes these days as routine screening. Cervical smears have been life-saving. And we have scans, we have x-rays. So these things have been something we've taken for granted for a long time, to the extent that now everybody expects a scan for every little thing. But general practice is underfunded compared to the rest of the health service. And I think if we had more GPs and we had more resources, we would be able to do a lot of diagnostic testing in primary care and take a lot of pressure off hospitals. In hospitals, of course, you've got laboratories on site. So there you probably have a more appropriate setup for PCR testing, for looking at biological markers in urine. And there have been some fascinating developments, haven't there? In recent weeks, we've read about possible biomarkers in urine for dementia. I mean, incredible. And the famous case of the woman who could smell on somebody's sweat Parkinson's hadn't yet developed. Remarkable circumstances, really. But if these things can be honed into tests which can detect prior to the development of significant diseases, we have an opportunity there to treat people much earlier and intervene to prevent the onset of significantly debilitating conditions. So yeah, I think it depends on the scenario. Is it a clinic? Is it a GP clinic? Is it a hospital? You're going to get different tests. But again, primary care is the gatekeeper. If you can work out that someone's got a significant illness, then you can refer them to secondary care for further tests.
So what I got from that was that every GP needs to have somebody who's going to go around sniffing the patient to figure out what's wrong with them.
You need somebody with that ability, and they're very rare. But whatever that person is sniffing, that's what we need to identify, that molecule. We can identify that molecule, then a machine is almost certainly going to be able to do it. The future is exciting in that, we will be discovering diseases earlier. And the same is true of genomic sequencing. If we can show which patients are more likely to get, colorectal cancer, we can intervene earlier. So genomic sequencing, I think, is something that NHS England want to make routine, part of routine care. And we know that people with colorectal cancer with a certain gene mutation are going to respond better to taking a non-steroidal anti-inflammatory like aspirin compared to people who don't have that gene mutation. So again, looking at genomics and personalized medicine is certainly going to be important in the future.
So one thing that's come up a lot in previous episodes of this podcast is that AMR is already hitting the global south a lot harder. So presumably this means that quick, accessible and portable diagnostics are kind of urgently needed everywhere.
Yes, they are. They are urgently needed. We need to know whether somebody needs an antibiotic, really needs one, and we need to know what germ we're dealing with, and that should be coming a quicker assessment. in the future with diagnostics. But I think there've only been two antibiotics in production in the last, I don't know what, 10 years,
Wow.
which is really worrying. We need many, many more, because there are common bugs out there, E. coli particularly, that's resistant to a whole number of commonly used antibiotics, the things that we would reach for first or second or third. Some people are getting really sick and being hospitalized with infections that are resistant to so many things that normally we just take for granted and take orally. And now we're having to give them intravenously or through other portals to get people better.
Something that also has cropped up with diagnostics, and this is something that you can probably answer, Dr. Hilary, is sort of what are the challenges with AMR in GP practices? So like, how do GPs need to manage patient expectations and also improve knowledge of correct use?
Again, I'm harking back to my early experiences as a GP. When I first started in general practice, we ran a personal list of patients. So I had 2,400 patients who were allocated to me.
Wow.
These patients would see me first if I was available at the surgery, which I was most of the time. We did our own nights and weekends back in that day as well. So we got to know our patients. So we would know if you, for example, was a stoic person whose notes were very thin and I hardly ever saw you, I would know that when you came to see me, something was really wrong, because I hadn't seen you for 10 years. So you come to see me with something, and I'm going to pay attention because, that's an unusual event. If, however, your neighbor came to see me and they came to see me twice a week with every little thing, my level of suspicion about this being a more trivial condition and not requiring antibiotics would be that much greater. And so I would know that knowing the patient's history, the patient's way of thinking helped me to make a decision about whether they should have this treatment or that treatment. Also, if somebody wanted to see me, I would see them the same day. I know right now people are having difficulty getting an appointment for 2 or 3 weeks, but if someone phoned me back in the day and they said, I really would like to see you, I would see them the same day. And that gave us a remarkable ability to assess them when they were acutely ill. And if we were worried, to say, well, look, you've got a sore throat and you've got a few glands here, but I don't think you haven't got a fever. Your appetite's good. You're constitutionally pretty well. I don't think we need to give you antibiotics for this reason. But if it gets worse, I'll see you again. And that continuity of care is so important. If only we could go back to that continuity of care where I would see you again. That hardly ever happens now. But I could see the same patient to see the evolution of the illness, how it was responding to treatment, whether it was getting worse, which with things like strep A, throat, or sepsis or meningitis is life-saving.
I find that so interesting and quite depressing, because obviously we're talking a lot about technology and gadgets and what kind of futuristic methods can we use to automate all of this. And basically what you're saying is it just needs like a person with the knowledge and the commitment and that relationship with the patient, that you can't really replace that with a machine, can you?
You can't. And interestingly, I was hearing the new department, the Minister for Health, Stephen Barclay, saying that artificial intelligence is the answer. That robots are going to read X-rays and scan results. And I'm thinking, no, please, you don't understand. You're going to need, that human experience to look at diagnostic images in conjunction with the knowledge of the patient. I don't believe, and I might be in a minority here, that technology can replace doctors. I think that there still needs to be that holistic approach. You need to combine the art of medicine with the science of medicine so that you've got an input into the underlying condition. And this over-reliance on technology, it has a downside as well. Technology has to be embraced, and it will advance medicine, but also it can get in the way a little bit. I mean, we have in years gone by wasted billions of pounds on IT systems that didn't work for the NHS, and that money could have been spent on new hospitals and more beds. But, thank goodness I'm not the Minister of Health, and I don't have to make these decisions. But I do think we need more doctors and perhaps less reliance on technology.
For sure, yeah, that makes a lot of sense. Just wanted to back up a little bit just to the point about communicating to patients and communicating why we can't overprescribe antibiotics. So I was just thinking about the fact that obviously, as I understand it, it's not that the individuals are becoming resistant to antibiotics, it's that the microbes are becoming resistant. So therefore, it's the reason for not overprescribing is more like for the greater good, right? So it's not necessarily specifically to the advantage of that individual. So is that hard to explain to people that,
Yes, of course. Yes. It's a very, very good question. And that is a common myth. People think that if they take too many antibiotics, they won't respond to antibiotics in the future. It's not them who's responding to the antibiotic, it's the germs. The germs will mutate and become resistant. So next time you need an antibiotic for that germ, the antibiotic won't work. This is commonly seen in women who have regular cystitis, for example, and kidney infections. The more antibiotics they take, on the assumption that it's an infection rather than just an inflammatory cystitis, the more they take, the more resistant the bugs become. And then they get a pyelonephritis, a kidney infection, which is a nasty infection that can lead to sepsis, which doesn't respond immediately to antibiotics. So their symptoms last longer and are more severe, and they can develop complications which could be life-threatening. So that's one example. Another good example, I think, is in newborn babies. We know the gut biome, the trillions of cells which line our gut and are important in our immunity and our gut digestive function and the production of vitamins, that biome is established at birth. And we know that three things can influence the gut biome. If we're born naturally, as opposed to through cesarean, if we're breastfed as opposed to formula fed, and if we don't have antibiotics in the first year of our life, our gut is likely to be much more healthy than the people who are, born by other means and have antibiotics and are bottle fed. It's simple as that. So again, restricting antibiotics if we can in the first year of life, restricting them whenever we don't need them. Only 50% of cystitis is caused by infection, but everybody assumes it's an infection. It could just be inflammatory. It could just need a change in the alkalinity of the urine, or, drinking more fluids or taking cranberry juice. And of course, diagnostic urinalysis sticks are very useful. We can see if there are nitrates there. We can see if there's blood or protein. They're helpful, very helpful. And now we've got things that you can hang in the toilet and men can pee on. It tells you if you've got any blood there. That's great. It's user friendly.
So I guess a final question is it could be sort of your personal take, but are you hopeful for the future when it comes to sort of antimicrobial resistance and just general treatment of infectious diseases? I'm
with the WHO on this, and I think it is one of the biggest threats to the human race. Antimicrobial resistance. It's up there with the WHO in the top 3 threats to the human race. If we lose the efficacy of all antibiotics, which is the way it's going, we're back to a pre-antibiotic era where 1/5 of children under 5 died of infection.
Wow.
Is it worse than before than the pre-antibiotic era, because we now have superbugs that have kind of evolved to become more resistant?
In many ways, yes. And we have a higher number of population living in crowded cities and towns, and with more mingling. Okay, so we've got the ability to isolate people, and we understand the importance of hygiene. We've got better hygiene, better housing on the whole, but globally we haven't. And as you say, there are these superbugs now which have replaced the pretty much more innocent ones of decades gone by. So it is a real worry, and I do hope that we are able to convey that message to the general public, who have just got used to medicine being a panacea for all ills. Read for a tablet, that'll bail me out of this condition. Our lifestyles and taking responsibility for our own health has got to be much more at the forefront.
Amazing stuff. So that's it from us, Dr. Hilary Jones. Thank you
Thank
so
you
much for joining us.
Keep up the good work.
Yes.
No colds and coughs.
No.
And the doctor's solution to a cold or a sniffle is the hot toddy, the doctor's prescription.
Yeah, we're doing that here.
Yeah.
Good. Pleasure.
Thank you very much.
Take care. Bye-bye.
And that's it from us this week. Thank you to Dr. Hilary Jones for joining myself and my colleague Lizzy Ratcliffe. Join us next week where our regular host, Alex Lathbridge, is diving deep into the topic of antimicrobial resistance in the environment.